Okay, is the microphone on? Everyone can hear me? Excellent. So, Minister for Energy, Minister for Industrial Relations, Minister for Safety, I acknowledge you. Also, health and safety officials from government, from industry, from unions, and from professional bodies. I just want to acknowledge you as well. I should also acknowledge the organisers. This is a blockbuster event for the first week of Safe Work Month, so well done to everybody who's been associated with this. I too want to acknowledge the traditional owners and custodians of the land on which we meet, and I respect their elders, past and present. In Safe Work Month, we also should acknowledge and remember those who have died in workplace accidents, those who have been seriously injured at work, and also those who have suffered an illness or disease from exposures in the past. I think we should remember their experience, if we like, and work towards improving workplace health and safety in our efforts. So this topic is obviously very large, indoor air quality and ventilation. Ventilation can be seen as a control measure for indoor air quality. And you're a sophisticated audience, so all I can really do here is give a curated view of this issue. There's lots of things to think about, there's lots of action happening. I hope to give you some idea of the most recent activities in this area, and so obviously take any questions that people might have in relation to these new interventions and ideas. So I'll talk about some of the history and recognition and management of indoor air quality. This is one of those things that we kind of drop the ball on in many ways. We tend to view a lot of this stuff as comfort rather than risk mitigation. So we need to think about risk mitigation in respect of ventilation, for example, rather than thinking about it just in terms of comfort. I want to talk about the context of indoor air quality and ventilation. Obviously, in any workplace, there is a context, and so I'll try to limit the presentation to certain situations, which will be very common, of course. Now, for those people who've got a history in occupational hygiene, you've probably heard the expression, dilution is the solution. And if we have enough ventilation, we'll obviously reduce exposures to a point where it's no longer a problem. That was old school thinking. I think we now need to think about the combination of ventilation with air cleaning devices in order to address issues of indoor air quality. There's obviously been a lot of progress in this field, and there's a lot of guidance and standards that have been introduced in other countries or are thinking about being introduced in other countries from which we can learn. And I guess we need to work towards an international perspective on this issue. Now, one of the areas that's becoming much more common is this idea of a healthy building and verification of a healthy building. So, for example, this building, is it healthy? Has it been rated? There's lots of schemes out there, Neighbours and Green Star and WELL and UL and so on. You'll see a lot more of these sorts of certification and ventilation verification schemes coming into play. And associated with that is more and more expectation about the kind of things that we ordinarily do in health and safety, training, education, awareness, review, and so on. That's sort of been missing in many ways in the field of indoor air quality. Now, you might think air cleaners are always good. Well, they're not always good in some cases, particularly if those air cleaners generate things like ozone or introduce a photochemical smog, which I'll talk about in a moment. So there's a question mark around the suitability in public health terms of particular types of air cleaners. And I'm using the term air cleaner in the same way as air purifier. Now, for those people in the audience who are regulators, how can we address the potential for regulation in this field? Because it hasn't been particularly well done in the past. What can we do? And where to from here? Where's the science taking us? What disciplines are really required to address indoor air quality in the long term. So what I will cover, what I won't cover, what I will cover is the focus on office-like environments, where people are people and there's, a wide range of different kinds of people. Office-like healthcare facilities and homes and things like that. There's obviously a lot of work going on in those areas. Indoor environments where we're talking about mechanical ventilation. That's HVAC with a building management system. So I'll try to orient this presentation around those mechanical ventilation arrangements. Situations where you might say, well, traditional workplace exposure standards don't really apply. We have workplace exposure standards for air contaminants, but generally speaking, they're higher than what we would consider to be acceptable indoor concentrations. Now, there is an exception to this. I think ozone is one of those which has a very tight exposure standard. It's got 0.2 milligrams per cubic metre as a peak value. Now, those in hygiene will know that anything with a peak value has got to be looked at in a special way. Whereas the National Construction Code has a limit of 0.1, right? And that's still lower, but in the context of control, a peak is actually more important. So in the case of ozone, we can think about regulating that in traditional office-type environments. Now, all of this is kind of contextualised in COVID-19. You can't avoid talking about indoor air quality without talking about COVID-19. We've learnt a lot and we're motivated to deal with this issue now, and a lot of research has been conducted in this field as a result of COVID-19. So I will make reference to that. I'm sorry you want to forget about COVID, but now we're still dealing with pandemics and there will be in the future as well. So we've got to learn about how we might use the built environment to facilitate risk mitigation. What I won't cover is industrial facilities where there are particular air contaminants generated, and I won't talk about industrial ventilation as in LEVs and testing and so on. It's really about general ventilation, the kind of ventilation we're experiencing in this room, for example. I want to refer you to an article written less than a year ago by Marowska, Marks and Monty, 3M. That might ring a bell, 3M. They made a plea, a clarion call for something to be done about healthy indoor air. And they argued that now is the time, because of COVID-19 in particular, now is the time to start making a step change in this field. And they referred to the example of John Snow. And those of you who remember the history of public health will know John Snow was a physician epidemiologist who was dealing with the cholera outbreak in London in the middle of the 1800s, and there were repeated outbreaks of cholera. So what he did was to identify where these occurrences occurred, and then identified a source of contaminated water. That was the transmission route, contaminated water, and took the handle off the pump so people could no longer take the contaminated water and experience cholera. At around about the same time, an engineer by the name of Joseph Bazalgette created the sewer system in London, which we now use for most cities as a form of control. The analogy was drinking water. We do a lot about drinking water, we test for it, we have all sorts of systems in place to make sure the drinking water is safe, and yet we don't really take too much control, if you like, of air quality. In the case of respiratory viruses and the transmission of infectious disease via inhalation of aerosols, we have the problem, similar to cholera, except as an airborne hazard, and we now need to deal with it. So it was a clarion call to everybody concerned with this, and particularly the medical community, to think about what can we do to improve indoor air quality to the point where it looks like drinking water quality. Okay, now of course regulation is a little bit tricky in this area because of lots of different reasons. Now we know a lot about indoor air quality. It's not like this is a new thing. If you have a look at the publications since 1990, there's an exponential rise in the number of peer-reviewed published papers that deal with indoor air quality. So this is not new. I published a paper back in 1993, so at the start of that curve, there was a little bit there, but now it's risen quite dramatically. So we can see that. And if you think about what types of air pollutants we are seeing a big rising, a lot of it's in relation to particles, because particles can be a proxy for some of the infectious aerosols. And even though we know more about this than we've ever had, we also know that indoor air quality, good indoor air is associated with better health, well-being and productivity. And in contrast, poor indoor air quality is associated with ill health. I guess you all know what sorts of things we're talking about with better health. One particular example that was published in conjunction with Harvard University was a pseudo-experimental study where they had office workers working in a building and they modified the supply of air, the ventilation, carbon dioxide, volatile organic compounds, and did kind of look like a randomised controlled trial to see whether or not the occupants of the building had better cognitive performance. And there was quite good evidence of that, 61% increase in cognitive performance for a green building, and that's mostly to do with VOCs, 100% increase when we're talking about ventilation and low VOCs. So the evidence is there that indoor air quality does yield benefits, and not just in terms of health, but also in terms of productivity. Okay, so the question is, do we have suitable indoor air quality criteria? Do we have suitable guidelines, standards, goals? Well, we do and we don't. NH and MRC published what it considered to be goals many years ago. They were rescinded. But the total VOCs as a measure of indoor contamination is still referred to in the National Construction Code. You'll still see reference to total VOCs of 500 micrograms per cubic metre in the Construction Code. WHO has got indoor air quality guidelines. We also have international guidelines and so on. So there's lots of stuff around. Some of it's country specific, but it is a bit messy. And so we are not quite sure whether these are suitable for a generic indoor environment. Should we use outdoor criteria instead? You know, the outdoor environment is presumably best. So is that good? Well, WHO again have got outdoor air quality standards. The problem is that's even being challenged by medical practitioners in the sense that it's not necessarily dose related in the sense that there's a value which is below the threshold for effect. We're seeing things even at the threshold that we believe to be the threshold. So the standards we have in outdoor air quality are not as good as some people make them out to be. So where does that leave us? We've got to settle on something. We've got to settle on some criteria, and there are a range of those available, but it's a question now of deciding. Indoor air quality and ventilation in context. I suppose some of you have been in this situation. Staff sometimes complain it's stuffy and there's odd smells, but the building manager hasn't told me of any indoor air quality issues in our building. Addressing indoor air quality, isn't that their problem? So do you really want to know about indoor air quality? I'm sure the building owners are probably more concerned about energy consumption, as the Minister said. There's a lot more to think about than just the quality of the air. So here's a quote from a recent publication. Healthy buildings today are not really healthy buildings, but they're rather not non-sick buildings. We know a lot about the health effects of some of these indoor air pollutants. We know about their impact on health, but we don't know very much about the totality of indoor air quality and how that relates to improving health. And by the way, is a sterile office actually healthy? Could you argue that a perfectly clean room, for example, with virtually no VOCs, is that a healthy environment to be in? Well, it could be, in one sense, if there's other people around contaminating a little bit and you're getting the benefit of those microbiomes. And so the building microbiome is a new concept, and there's a lot of work going on in terms of understanding how we can use that microbiome to improve health. So that's taking it from a slightly different angle, that not only are we talking about reducing air pollutants, but we might be talking about introducing some contaminants that are actually beneficial for health. Okay, so indoor air quality, we use the term indoor air quality loosely. It's a analysis, or it's a measure, if you like, of the chemical, microbiological and other aspects of the air. And so that's not just the indoor environment that we're talking about here, it's also the environment that impacts on the air intake and so on. It's not just the actual building, it's the surroundings of the building. If we think about indoor air quality from the point of view of the impact of the determinants of indoor air quality rather than just what's there, that is the way we should look at these issues. Then there's a question of what's acceptable. What's adequate indoor air quality? And that's a bit subjective. The ISO standard here is actually really confusing. It talks about the idea that not everyone will be protected, and that it's a bit like the workplace exposure standards, where the majority of people will be protected, but not everybody. So what are we talking about here in terms of indoor air quality criteria? We have to accept that some conditions will not be perfect for everybody, but we've got to make sure that the overall health benefit is there. Ventilation, well, yes, we reduce the concentration and therefore the risk is reduced. And of course, we're taking air from a space which is clean and putting it into a space where it's being occupied. And we can express the ventilation in terms of air changes per hour, or for individuals, litres per second per person. I guess you're all familiar with Australian Standard 1668 Part 2 about what that actually means. Doesn't really talk about air changes per hour. That's something that we have to determine empirically. So ventilation is not simply air movement. And poorly controlled ventilation, in other words, poorly directed ventilation, can actually increase exposures. So this is a diagram out of one of Morawska's publications. You can see that if there's a source at some distance from the susceptible person, if you blow air at the source towards a susceptible person, then their risk actually increases, for all other factors being equal. So we all know this. This is the source pass receiver model of occupational health. It's surprising how little that's actually applied when you talk to engineers or other people. They just don't understand this concept, or at least they don't quite understand the concept. And the other thing about air is it has the effect of drying membranes, drying skin and so on. You just can't put a lot of air on a person and get away with it. It's not that simple. And as the Minister said, energy consumption is a big factor in providing heat or cooling and ventilation. Something like 42% of all the total greenhouse carbon dioxide emissions come from buildings, whether they be in the construction phase, materials being used, and 27% is actually to do with the operations of the building. We've got around about 15 million buildings in Australia. Okay, that's every little structure, not just the big ones. So anything that we can do to reduce energy consumption, better, smarter thinking about ventilation, smarter thinking about heating and cooling, is going to have a beneficial effect in terms of the climate. So I just want to reinforce what the Minister said about the nexus between energy and providing a risk management strategy like ventilation. And of course, as we know, that ventilation is only one layer in the multi-layer approach that we use to mitigate risks. And the layering, of course, is from the hazard control hierarchy. So we can see how this fits together. We just have to join the dots and make sure that we're covering all those areas of comfort, energy efficiency, and risk mitigation. Now, if we think about what we tried to do during COVID, and we still got it, by the way, there were a lot of what we call non-pharmaceutical interventions. So that includes travel restrictions, social distancing, communications, masks and face coverings. But if you look at the ventilation aspect of reducing coronavirus disease transmission, the evidence from a recent review is that was partially effective. It did actually work. So it's not like it doesn't work at all. What didn't work particularly well was the hand sanitisation and looking at it from the point of view of traditional infection control. We do have more to do with ventilation in terms of infectious disease. And of course there are confounders in all of this, but the evidence is fairly clear that we did have a good outcome there. So is dilution the solution? Yes, up to a certain point, provided the air that's coming in is not minus 20 degrees or plus 50. We have an acceptable air quality, including temperature and humidity, but there's a price to pay, of course. And air cleaners now are used to supplement dilution with outside air. That can actually increase the number of air changes per hour from, say, 2 to 5, because you know that most of the air is actually recycled in commercial buildings. So when we recycle the air and we clean it, we're actually getting effectively more air changes per hour. So there's a really important consideration here that you can supplement and need to supplement outside air intake with air cleaning as well. And that reduces the energy consumption as well. So there's a benefit there. And people are using air cleaners and air purifiers now every day. So it's not something that's out of touch with most people. Having air cleaners, air purifiers within an HVAC system is also very efficient. And that's, again, reducing energy consumption. So we have both types now that we can use for indoor air quality control. Here's a case study where we looked at an unoccupied building, and this was in the CBD of Adelaide, and we were testing a air purification system in the HVAC system, and everything was going really well. The particle counts were low because the air cleaner was doing its job. But then when we looked at the values of particle count of outside air, it was rising quite dramatically. Didn't understand why. We couldn't sense it inside the building itself. There was no smell. But what was happening here was that there was a programmed smoke, programmed event where you bushfire burn, and that in Adelaide is in the eastern suburbs or in the hills. The smoke from the prescribed burn was going into the CBD and affecting people, or potentially raising the levels of particles quite dramatically. So it was interesting to see what effect did that air cleaner have on reducing those particles. And it did. The one on the left is the particle count during the smoke event. It's highlighted there. It's quite a significant increase. The one on the right is the outlet, if you like, of the air purifier, but the scale is quite different. It's 20 times less. So we're getting about a 95% reduction in bushfire smoke through that sort of air cleaner. And we're talking about size ranges which are sub-micron. Okay? We're not talking about large PM10 stuff. We're talking sub-micron. Can we get a significant reduction in bushfire smoke by using air purifiers? In theory, you can. In practice, this was a Victorian study where they issued portable freestanding air purifiers in houses that are in the semi-rural areas of Victoria, and they had monitoring of particles outside the house and they had monitoring of particles inside the house, and they were able to show, under real-world conditions, because people like to open doors and windows and all sorts of other things, they were able to show, well, I would say it's a fairly modest reduction, 30 to 74% reduction in particles as a result of using that single air purifier in a single room. Not a huge benefit, not 95%, but that's the real world. Of course, there are all sorts of issues with air purifiers, as you probably know. Those ones that have charcoal, small amounts of charcoal are generally just gimmicks. They don't actually do much after the first few hours. It's the HEPA filters that actually do the work. Okay, so where are we with progress on ventilation guidance and standards? Some of you will know that ASHRAE issued a new standard on the control of infectious aerosols. And this standard 241 may well be referred to in Australia. It's really talking about how you control infectious disease through either enhanced ventilation or air cleaning. So there's two choices there. The problem with that, of course, is that, let's say, for example, in this building we have compliance with that standard. It means that during the pandemic, there's enhanced ventilation, either increased outside air or they have, air purifiers being kicked in and reducing the aerosol concentration. The problem is we don't know when those events actually are going to occur. I did ask a statistician in a health department, how would you know if there's a pandemic on the go? How would you know the start of the pandemic? And they do have control charts, so the epidemiology branch does have control charts where they can see an exceedance beyond the normal limits, but that hasn't been done before. So it's good to talk about in the event that you need to turn on this infection management control mode. We just don't have any experience with doing that. So then there's a question of, well, do you just leave it on all the time? Do you just assume that people are infectious and just have these systems on all the time? And what about the cost? Okay, so the secret here is to purify the return air so you don't end up with just the effect of one filter that's used as the system. You actually have a combination. CDC, the US CDC, talk about 5 air changes per hour. Now, in a building like this, I don't think you'd be getting more than about 3 air changes per hour, but it could be improved to 5 without introducing a whole lot of outside air by using air cleaners in conjunction with the standard HVAC. The trouble with using HEPA filters, of course, is the back pressure on those is so great that you'd have to have a different system altogether. And that's not to say we won't ever have HEPA air filters in standard air conditioning, it's just it's not feasible at the moment. I did talk about healthy building verification. So what are we talking about there? This is where you imagine a whole system designed to address indoor air quality. Here's an example of a medical practice that is office-like. It doesn't have any aerosol generating procedures or other things that make it look like a hospital. But still there's concerns about patients in waiting rooms and close contact with other people. So the UL certification or verification system was applied for in this Mount Barker medical clinic, and it's actually quite sophisticated, and it gives you a pointer as to what you'd expect to happen in the future here. Okay, so the plan, the indoor air quality management plan, is quite extensive. There's 10 pages with a whole lot of stuff about training and record keeping and this, that and the other. But then there's also other requirements like mould and moisture response plans. We're talking about preventative maintenance here. We're talking about hazardous materials as well, like asbestos and so on. So the difference between this and what we might see ordinarily is that the driver is an outside organisation. That's not really all that new, but a holistic approach is being used. So that means a verification notice on the door, an entrance. There's also staff being trained. They are reporting and investigating themselves. They have systems to look at the way the system works. There is indoor air quality testing as well, of course, and all those things that you'd expect to see for a hazardous environment. Training, information, documentation, that sort of thing. And also airflow patterns, which is, I think, quite an important aspect of any ventilation system. So this is probably top end. This probably, in some cases, might be seen as over the top. But in the context of a health clinic, where you may have sick people coming in, you don't want to transmit disease, this is probably where we're at in terms of best practice in indoor air quality. Okay, now you can couple sensors to all of this, and I think that's quite an important aspect of where we're going as well. Remember I said that Morawska, Marx, and so the 3Ms, yes, we're arguing that we can revolutionise indoor air quality by having this approach, treating it like a water quality system. But not all air purifiers are safe. They're arguing that there's an argument to say that some of these air purifiers are actually creating a problem because they're generating ozone or creating a photochemical smog. I won't go into this into detail, but there was an interesting seminar from the US EPA on this topic. And Jose Jimenez, some of you may be familiar with the name. He's a US-based researcher who was arguing that some of these air cleaners are actually creating a public health problem because of the generation of photochemical smog. Some of the UV disinfectants, the upper level and the 222 nanometer source, if you like, where we're irradiating people with UV, is going to get rid of the bugs. Well, unfortunately, it might get rid of the bugs, but it then creates photochemical smog within the room. So you're producing ozone with UV, and that interacts with volatile organics to give you secondary aerosols, and those are the kind of aerosols that you see in big cities with photochemical smog. Now it's not something that's been developed particularly well. It's really just a word of caution. Not all air cleaners are going to provide the kind of benefits that one would expect. I won't go into the detail here, but here's a room, an office where the UV was switched on for periods of time. The ozone level increased, as you can see, depending on when the thing was switched on. And in a separate experiment, they showed that when you introduced limonene, which is a cleaning agent, some of those terpenes are used in air fresheners and cleaning agents. When you have that present along with ozone, you form secondary aerosols which build up. The limonene drops, the aerosols increase. Which is worse? The aerosols, because they are associated with mortality. We know that from outdoor air pollution studies. So the 6 cities Harvard study was used as an example of why we need to understand this factor, and a risk was calculated on the basis of that. Now, it's all very hypothetical. I don't want you to imagine that we know now that there are disbenefits associated with air cleaners, but there is a caution here about which types of air cleaners should be used. Here's a list of air cleaners. They all disinfect, or they all remove, but some of them also create the photochemical smog. And on this chart, the ones that are above the line are generally good. The ones that are below the line are problematic from the point of view of secondary aerosol generation. You wouldn't know this. I mean, how would you know? I mean, these are very small particles, and we use air fresheners and disinfectants all the time. But we now know that the use of limonene-based cleaning agents and so on is creating a potential air pollution problem, particularly with certain kinds of air purifiers. Okay, what about regulation? Well, as you all know, there has been some attempt to encourage politicians to address clean air. I mean, what that will look like in the end, we're not quite sure, but I think there's motivation now amongst a whole lot of politicians that we need to do something about this clean air issue. In the US, there's now a model act for states to work on indoor air quality. So this is perhaps an example of where our regulation might go. And it's not just monitoring, it's also training, education, and focused on the building owners. In here, we're talking about public health benefits, which are quite significant. For every dollar invested in indoor air quality, when we're talking about public health, there's a benefit that's greater than the cost. So from a public health perspective, public health spaces or public spaces, we should be addressing that as a public health measure. Obviously, workers are working in public spaces, in airports and all sorts of other places, so there's benefit for workers as well. I think this is a starting point for where we might be going with specifying some of the regulatory requirements. Of course, OSHA tried to do this some years ago. The Occupational Safety and Health Administration tried to have a comprehensive rule about indoor air quality, and that got jettisoned. That was rejected. So they've tried it once before in the United States. This is a different model. This is working on the states individually and giving them the kind of criteria and the expectation addressed at building owners and managers that might address the same kind of problem. What about due diligence requirements of officers under work health and safety legislation? Do they just unaware of these kinds of things? I think you could argue that under the regulatory requirement for health and safety duties of officers, they need to understand what's currently in their work, well, the purview of their work, but they also need to understand the control measures. So I think there's a way forward in relation to addressing this kind of broad issue with senior people in boards and so on. As you know, there is a due diligence index. I don't know whether you've heard of that one. Some of that due diligence index can be crafted to look like indoor air quality, for example, and that may be a step that pushes these PCBUs and directors and so on to do something about indoor air quality in a more formal way. So where to from here? Well, this is very much an interdisciplinary problem. From a science perspective, we know that the science is being driven by the problem, which is air pollutants and health issues. We need to fix it. There's also new technologies like CFD, computational fluid dynamics. We have a lot more sensors these days. Some of you will have sensors in your home for indoor air quality. These are relatively cheap and they can give us information that's cloud-based, can be interrogated. We can actually do more than what we're currently doing with those sensors. And not only that, they can be rapidly communicated and problems fixed. So the technology is there now for monitoring the indoor air quality. The science is gradually getting better in terms of how we control these things. And so I think that's where that science aspect is going. This diagram is a little bit complicated, but in the old days, we used to use epidemiology. We used to go around and do symptom surveys and all sorts of things like that to understand indoor air quality and symptoms that people experience. Nowadays, it may be possible to monitor these things almost in real time and get information back to fine-tune the ventilation system and fine-tune indoor air quality as it relates to people. I just want to put in a plug for the QUT International Laboratory for Air Quality and Health and their ARC-funded industrial training transformation project where they're actually looking at how we can do this. So that's been kick-started this year. and it involves a whole lot of different disciplines. The key point here is that we're not just addressing comfort, we're also addressing energy efficiency, and we're also talking about risk mitigation. So those three things have to go together, and how we do that in a built environment is something which will be, I guess, the future direction. This is my own little diagram of where we're going with ventilation and where we've been. I won't go onto this in any detail, just the first column is probably the most relevant. In the old days, we used to think about dilution as the solution. Now we're talking about dilution with air cleaning. The third iteration of this is dilution, air cleaning, and directionality, because we know directionality modifies the risk. So if we take an example here of, on the right, traditional mixed ventilation arrangement, everything gets mixed up, people get exposed, transmission occurs. On the left, we have a slightly different ventilation arrangement, which is more directional and is catering for the infectious aerosols that are present because of other people in the environment. So that's a different sort of angle to traditional general ventilation. Right, take-home messages. I think we're at that turning point now. Remember that analogy with the handle on the Broad Street pump? Get rid of your cholera problem by cutting off the source of the problem. We have to accept that now we have enough information that we can move in this direction and document it in a way which is holistic. There are new standards and systems. They will, I guess, eventually be incorporated into the way we manage health and safety. And this is because of COVID-19 to a large extent, and also because people are working from home more often. Workers are, thinking, well, if I go to my office, am I going to get infected? Is it better for me to stay at home? How effective are these ventilation systems anyway? Do I even know what's going on with the HVAC system? Have I ever seen an air handling unit? Do I know where the air intake is? There are legitimate questions to ask in relation to this. More advanced building systems will emerge, and they will address energy efficiency and comfort, and the use of sensors will make the whole lot easier. If you can monitor, I guess as you probably all know, what gets monitored gets done. If you don't monitor, you don't understand indoor air quality, even at the very basic level like PM or carbon dioxide, I think you're going to be very subjective in how you're addressing this kind of issue. So what's the role of the health and safety professional in all of this? Well, it's no different really from any other hazard. It's just that we've tended to imagine that building owners and managers are the only ones who ever need to understand these kinds of issues. We need to understand it as well. We need to have an advisory role, and it's almost part of normal work health and safety management systems. As we've seen from the Better Medical Health example, they do have a management plan, and it doesn't look all that much different from what we normally do with a range of hazards. The nature and the scope of a specific regulation of indoor air quality will evolve. Whereas we have traditionally used voluntary healthy building criteria and so on, I think if we can build on that and reinforce voluntary efforts, we'll see a greater number of these buildings with what we would consider to be better air quality. So I just want to leave it at that point and hopefully ask any questions if you have questions.
Dino, thank you very much. There'll be some and my apologies, my phone just went off. There'll be some very sophisticated questions asked here today, and I'd just like to throw in a couple of my unsophisticated ones. Firstly, do you use an air purifier in your own home?
Yes.
Secondly, do you have a can of Glen 20 in your own home?
Yes.
Just wanted to know. And the third question probably, if there are 15 million buildings in Australia, and this is but one of them, Can you walk into a room like this and say, I sense it is healthy or it is not sick?
Okay, so we could be sitting in an atmosphere of infectious aerosols and our comfort level would not change one bit. Okay, we don't know whether or not there are these things in high concentrations or low concentrations. We just don't have a sense of all of that. So it would be much better to have sensors, as we do for radiation and other hazards. We have sensors that tell us something about what's going on in this building. Some people bring their own carbon dioxide meter when they go to a restaurant. I know Kate Cole, are you familiar with Kate Cole? She's the ex-president of AOH. She used to go in with a carbon dioxide meter into a restaurant, and if it looked as though it was out of control, then she wouldn't spend time in there. But yeah, I do have an air purifier. I don't use it all the time. I would use it when it's likely that there is a problem. You know, for example, if I'm doing some work where it's just been generated, I would use it. But I know from the sensor on the air purifier what the level of dust is. So it's not just purification, it's also telling you what the concentration is. And I can, as a scientist, I can see how that varies with time. So that's an important consideration. Glen 20, very important for disinfection, alcohol and so on. At one stage, we were thinking that Glen 20 might be suitable for reuse of respirators. You know, the P2 respirators have got electrostatic charge on them. If you spray water on them or put water on them, that disappears and most of the efficiency drops off. But there's a question mark about whether you could have an atmosphere of alcohol, disinfect the bugs and still retain the efficiency of the respirator. So I do have Glen 20 and use it for surface contamination and, yeah, by and large, porous surfaces.
Thank you very much. It wasn't such a bad question. Dino, why are so many room filtration unit filtering at 10 micron, which is relatively ineffective when it should be at less than 2.5 micron, asks one of our audience members.
Okay, well, I have a view about that. PM 2.5 is what's traditionally used as the fine particle guide. PM 10 used to be. PM 2.5 is probably more predictive of what we see with outdoor air pollution mortality. PM 1, I could talk about this for quite a while, but PM 1 and less is really what we're dealing with diesel exhaust, what we're dealing with engineered stone. There's no reason why we can't do PM 1. I mean, instrumentation exists these days. We're doing PM 1, PM 4, PM 2.5, PM 10. For some reason, we've fixated on what I would consider to be an old standard of respirable dust. I think we need to move away from, for some of these hazards, away from gravimetric measurements to numerical measurements, and we need to go to smaller particle sizes in recognition of exhaled aerosols and so on.
I think you touched on this in your presentation, but some countries, for example, Ireland, have introduced a mandatory code of practice for indoor air quality. Are you aware of any moves to introduce the same in Australia? Perhaps you could twist that question a little bit to say how effective and how considerable is the challenge of seeking to introduce mandatory codes of practice? Personally, I don't think it's that difficult. People need to put their minds on it. Just need to identify all those areas where we could make a difference in terms of regulation. Make everyone aware of why those aspects of regulation are important. And there might be a cost-benefit ratio associated with that, but I don't think we've really documented what we need to document in indoor air quality. I'd like to see some indoor air quality regulations which give responsibility to officers and so on. Is it an awareness issue? I know for people in this room it is not an awareness issue, but publicly is it an awareness issue?
Of indoor air quality?
Yeah.
I think so. I think people are now questioning why they would want to go back to the office or why they would want to send their kids to school where they know that there are air pollutants in the environment. So I think the awareness is much stronger because of COVID more than anything else.
Any comments on the cleanliness of ducting and in particular return air pathways? ERA, I hope I've got that acronym correct, has guidelines, but they don't seem to have gained much traction.
You're talking about return air ducts, or you're talking about the return air mixing with the...
I'm sensing it's returned air ducts, but the question comes from an anonymous asker.
Okay, well, if I'm sort of interpreting this correctly, if you've got contamination in the work area or in an indoor environment and you return the air, then and you don't clean that air properly, then you can have a compounding problem. If there's contamination in the ductwork to start off with, you've got a real problem. You need to fix that. So there's an issue around knowing the airflows, knowing exactly what's happening in each part of the ventilation system. As you would, in your normal house, you would look at a whole lot of these factors with some degree of interest because you spend all your time, people come into your house, they look at things. So it's no really different, I think, with indoor air quality.
Where should old buildings, hospitals, focus their air quality efforts? And there's another question that relates to this as well, and an observation that a real challenge is not new buildings, but the prevalence of older buildings and the excessive cost of modifying or reconfiguring setups. Do you have some advice? So where should hospitals focus their efforts, and what is the particular challenge with an older building?
Look, there are definitely challenges with older buildings in terms of ventilation and so on. But I think we should apply the basic occupational hygiene principles here. Who are we trying to protect? Where's the air going? Is it contaminated for a reason? Is it variable? How much is there? Even with an old building, you can do quite a fair bit about tailoring a solution without spending millions of dollars on a new HVAC system, although ultimately that will probably need to be done anyway.
Okay, I realise time is going to beat us, but I really like the fact that so many people have so many questions. Could we just finish on this then? Where are we? What are three things, but there might be one or there might be four, so that's up to you. What are three things we could recommend provide to our employees who work from home to improve their home IAQ?
Well, I think an air purifier might be one relatively low-cost step, at least having it available for usage, even though it doesn't necessarily work quite as much as well and for as long as one might imagine, but at least that is one option that they can use. Venting contaminants outdoors, if you've got unflued gas heaters or something like that, you're in big trouble. So you need to understand where the indoor contamination is and reduce that as much as possible. New materials, new paints or whatever, there's also that aspect as well. I think there's a lot of stuff around these days for people who want to go green, and I think that's a starting point.
Ladies and gentlemen, would you please thank Dino? Incredibly educative, understandable even for someone like me. Thank you so much for being with us today, Dino. It's a great pleasure having you here.
Thanks, Jeff.
Thank you, mate.